We're excited to finish up here with the best of ASCO, and Vidya is going to share with us some great updates. And you were our representative at the Benetera, so way to go! Thank you for doing a reprieve of your presentation for us.
Yeah, happy to talk about these two abstracts that I'll be covering, which were basically the two hottest topics I think from ASCO in terms of the breast cancer studies. Can everyone see my slides? Okay. All right. So the two ones that we'll be discussing today are Destiny Breast 09 and Ascent 04. Just move this. In terms of Destiny Breast 09, the first thing I think we should kind of cover is just making sure that we review some background on metastatic HER2 positive breast cancer, which we're all quite aware of, but it's important to know the kind of where we are at today in terms of what has been previously or what has gotten to where we are today in terms of our current lines of or our current standard of care. For first line HER2 positive metastatic breast cancer, HER2 directed therapy was first established back in the 90s that showed that a combination of trastuzumab or HER2 monoclonal antibody in combination with chemo significantly improved progression-free survival over chemotherapy alone at 7.4 months with combination of chemotherapy and trastuzumab. This is then followed by the Cleopatra study, which has established our current line standard of care in the first line setting for HER2 positive metastatic breast cancer, a landmark study showing that the combination when adding trastuzumab and chemotherapy to pertuzumab led to significant improvement of median progression-free survival as well as overall survival. We see that the landmark overall survival here at 8 years is 37% versus 23%, and landmark progression-free survival at 8 years is 16% versus 10% with the triplet therapies. Oops. And then the next study to go over is the Bettina study. This was presented at SABCS in December. So this was looking at now triple positive, so hormone receptor positive and HER2 positive disease, trying to establish a new standard of care for our first line setting, specifically looking at our maintenance therapy. So all of these patients had induction treatment with the Cleopatra regimen THP. And once they achieved best response, were then initiated on their maintenance therapy of HER2-directed therapy as well as endocrine therapy. The control arm received dual HER2-directed therapy with trastuzumab and pertuzumab, in addition to endocrine therapy, either aromatase inhibitor or tamoxifen. And the intervention arm included an addition of a CDK4/6 inhibitor, specifically palbociclib. And the results that were presented at San Antonio showed that the median PFS was 44.3 months with the addition of palbociclib versus our current standard of care of HP with endocrine therapy that was 29.1 months. So this was a big update that recently occurred. And then we also know that TDXD has been shown to be quite effective in previously treated HER2 positive metastatic breast cancer. Destiny Breast 03 was what looked at second line treatment of for HER2 positive metastatic breast cancer with TDXD versus TDM1. And it showed that there was a significant improvement in progression-free survival with a delta of 22 months and an overall survival that was, well, in this not reached, but statistically significant here of improvement in overall survival. So now that brings us to the Destiny Breast 09 study, which was evaluating TDXD in combination with pertuzumab versus our standard of care, trastuzumab, pertuzumab, with a taxane as first-line treatment for metastatic HER2-positive breast cancer. So, as a background in terms of the rationale of combining pertuzumab with TDXD, the investigators felt that there was enhanced efficacy of TDXD by adding pertuzumab because it does bind to a different epitope at HER2, and so therefore causing inhibition of dimerization, and the dual HER2 inhibition can then also enhance tumor effects by allowing TDXD delivery of its payload. And so here was a study design. This is included patients, so HER2 positive metastatic breast cancer. They did allow for asymptomatic or inactive brain metastases. They did allow for patients who had, or they required patients to have a disease-free interval of more than 6 months from their last chemotherapy or HER2 targeted therapy in the early stage, so either as neoadjuvant or adjuvant treatment. 1 line of prior endocrine therapy in the metastatic setting was permitted, but no other prior systemic therapy for metastatic disease was allowed. They stratified us based on de novo disease versus recurrence, hormone receptor positive versus hormone receptor negative, and they also stratified based on PIK3CA mutation. So the initial design was TDXD alone for the first arm, second arm being TDXD with pertuzumab, and then the control arm being THP. And their primary endpoints were progression-free survival, secondary endpoints of overall survival, and PFS2 overall response rate. Some important things to also note is that if there was TDXD discontinuation due to any adverse events, patients were allowed to switch to trastuzumab. And then in terms of concurrent use of endocrine therapy with AI or tamoxifen, this was allowed for patients after they received 6 cycles of TDXD or once they discontinued the taxane in the THP arm. So they screened a total of, or they randomized a total of 1,100 patients, and you can see that they were kind of evenly represented between the 3 groups. And they, at the ASCO meeting, they presented the arm of TDXD with pertuzumab and versus the control arm. So here you can see that 20.8% of participants discontinued TDXD due to an adverse event. And only of those patients, only 8.7 then switched to HP. And another important thing to note here is that only 13% of those in the TDXD arm received concurrent endocrine therapy, while 38.3% received endocrine therapy in the THP arm. And at the data cutoff, 45% of patients still remained on TDXD. And their median duration of follow-up at the time of presentation was 29.2 months. So then in terms of the patient demographics, key things to note is that majority of the patients enrolled in the study were from Asia. And that's important to know based on what their subsequent lines of therapy will be, because that significantly, I think, is going to impact the final results of this. Because as we know, TDXD is not readily available in all other countries as second-line treatment. And so that will affect the overall survival when we're thinking about the control arms as well. And we'll talk more about that in a few slides. Other things to note, there was a slightly higher representation of hormone receptor positive participants in both arms versus the hormone receptor negative. And there was a large proportion of patients, about 50 patients in each arm, that were de novo at diagnosis. And also, interestingly, there was 30% of patients represented that had a PIK3CA mutation. So of those with that had the endocrine therapy, I'm sorry, not endocrine therapy, and for those that had THP, 85% of them had uh, chemotherapy and 58% had trastuzumab, and then only 15% had pertuzumab. And this is actually for prior lines of therapy. So this was in the early stage. So for those who were treated previously with early stage breast cancer, only 85% of them had chemotherapy, and very few received pertuzumab. So primary endpoint was progression-free survival. You can see that there was a statistically significant and meaningful improvement in PFS at 40.7 months of TDXD with pertuzumab versus 26.9 months with THP. And so this was a delta of 13.8 months. In terms of the subgroup analysis, we can see that the benefit was regardless of de novo disease, of their hormone receptor status, as well as for PIK3CA mutations as well. And so I think that's also an important thing to note here is we know that oftentimes these patients may have more aggressive disease. And so overall, it does seem like that the benefit was consistent throughout these groups. Looking at overall response rate, was it improved with TDXD and pertuzumab at 85.1% versus 78.6% with THP. And we can see that there was also a higher amount of complete response with TDXD and pertuzumab. And then when we look at median duration of response, also longer, 39.2 months with TDXD versus 26.4 months. So response rates, again, seem to be durable with TDXD. So then they presented PFS2. The investigator did state that overall survival was immature, and they defined PFS2 as time from randomization until progression on second-line treatment. So you can see here that for the group that received THP, only 10% of patients receive subsequent TDXD as their second-line treatment. And this is kind of going back to what I was referring to earlier, and the fact that majority of the participants on the study were enrolled in Asia. And we think that that is likely why so few of the patients receive TDXD in the second line. And you can see a higher frequency of other trastuzumab containing agents as well. In terms of overall safety, I think there was nothing surprising here in terms of safety data. However, it did look like rates of discontinuation were actually higher with the chemotherapy with THP, which I think is slightly surprising, as we do feel that, knowing the toxicity profile of TDXD. However, there were more dose interruptions with TDXD and pertuzumab. And in terms of treatment-related AEs with an outcome of death, it was higher with TDXD. Another important thing to look at was the median treatment duration. So this is, I think, also quite surprising, is that we see that TDXD median duration was 20 months, so quite long, versus THP of 19.9 months. And I think one of the criticisms of this trial is that the quality of life with patients on THP, once they've moved on to their maintenance treatment, is much higher. And so seeing patients in a first line treatment on 20 months of basically chemotherapy is quite, I guess, notable. Well, they also uh, told us about the duration of median duration of taxanes, 5.5 months with docetaxel, 4.4 months with paclitaxel. So again, kind of looking at these numbers in terms of how long the patients on THP are on chemotherapy versus 20 months of T-DXd. And median number of cycles of taxanes is quite similar to what we see in the real world. So now moving on to adverse events, we can see that there were more any grade adverse events with T-DXd, specifically related to ILD and pneumonitis. This is actually higher than I think what is typically reported in the other Destiny breast trials for ILD incidence, so slightly higher ILD on this study. LV dysfunction was also slightly higher too at 11%. So the key takeaways is that this study did show that the median progression-free survival was improved, was 13.8 months longer with T-DXd and pertuzumab versus THP, and the median duration of response was over 3 years. No unexpected toxicities. However, there were more dose interruptions and dose reductions. And, we also note that more dose interruptions and reductions with T-DXd associated with a longer duration of response. So I think that the main takeaways from this trial was that, yes, we did see longer progression-free survival. However, the answer of whether or not using T-DXd in the first line versus waiting for progression after maintenance therapy and using it as second line still can't be answered because they didn't quite allow, well, not that there was no crossover allowed on the trial, and very few patients allowed for subsequent or receive subsequent T-DXd. So unfortunately, we won't be able to have that specific question answered. This kind of is highlighting that too. And then the other question too is how do we select for those patients who have this early progression on THP? So it seems like there is about 25% of patients that do have this early progression. And so do we and this study unfortunately wasn't able to give us that answer in terms of how we can select for these patients and who are those most high risk patients. And then because we do know that there is that prolonged benefit on THP with a long progression-free survival at 8 years. And then also thinking about quality of life as well, because we know that the quality of life is significantly better for patients who are just on maintenance therapy with HP and endocrine therapy versus, doing 20 months of T-DXd. The other big question was, what about doing an induction of T-DXd followed by a maintenance? How would that change the results? So there's actually a phase 2 study called the Demether trial, which is unfortunately a single arm study, so it won't necessarily be able to give us comparison data in terms of which is actually if they're equivocal or if one is actually better. But at least we will have hopefully some answers from that study in terms of looking at how to incorporate potential an induction regimen similar to what we do with Cleopatra regimen. And then for our triple positive patients, how do we think about these results and compare it when we also have the recent Patina study that showed a very long progression-free survival when we've slightly escalated our endocrine therapy maintenance as well. Does this data really apply to those patients? I think we don't know the answer to that question right now. So I'll pause for any comments or questions or anything to go over, because that was a big update in terms of studies that were discussed.
Thanks, Vidya. Great job. Every time I see this, it still gives me a lot of pause and about this approach and even how well we know THP and patina work, but be ideal if we could understand how to optimize or how to use ctDNA to see if you clear early with TDXD, can you go on to a maintenance strategy afterwards to try to avoid that long-term toxicity associated with therapy? I'm sure others have thoughts as well.
Yeah, I'd be curious to see if something like ctDNA or other types of um, um, other types of interventions we'll be looking at in that single arm phase 2 study with that's looking at induction for TDXD, but that's a great point. Okay, well, for the sake of time, I'll move on to the next. Um, so this was covering for metastatic triple negative. And just as a background, thinking about the treatment landscape for metastatic triple negative breast cancer at the current time, we know that in the first line for PD-L1 positive patients, we are treating patients with pembrolizumab in combination with chemotherapy. For PD-L1 negative patients, we are treating them with typically single agent chemotherapy, and this is based on the Keynote 355 study. And then in the second line, we're using sacituzumab, which is based on the ASCENT study, or potentially using TDXD based on Destiny Breast 04. Then maybe sequencing these based on their HER2 status. And then also thinking about any other targeted agents for specific to biomarkers and using PARP inhibitors in the setting of germline BRCA mutations, and then just our standard chemotherapy. So just as a review for our Keynote 355, this was chemotherapy versus chemotherapy with pembrolizumab in the first line setting for triple negative breast cancer. This showed specifically for the subgroup of patients who are PD-L1 positive, defined as a CPS score of 10 or greater, that there was a improvement in median overall survival of 23 months with pembrolizumab versus 16.1 months with chemotherapy alone. And so this is what really established our standard of care currently. The ASCENT trial is what investigated sacituzumab as subsequent line treatment in the triple negative setting for metastatic disease. This was a landmark study showing both progression-free survival benefit as well as overall survival improvement. Other important things to know that in this study, when this study was perform, or when the study was done, 49% actually did not receive second line treatment in the real world at that time, and 34% actually had have died receiving second line treatment in the real world as well. So the ASCENT 04 study was looking at combining sacituzumab with pembrolizumab in the first line setting versus chemotherapy with pembrolizumab for patients who are metastatic triple negative and previously untreated who were PD-L1 positive. So the study design, again, these had to be untreated patients, metastatic triple negative. CPS positive was defined at, or PD-L1 positive was defined as CPS of 10 or greater, as was defined in the Keynote, or as was based on the Keynote 355 study. They did allow, or patients had to have at least 6 months since their treatment in the curative setting. Prior PD-L1 use was allowed. However, there was very few patients that actually did have prior PD-L1 use, and we'll go into detail about that in a few slides. And patients, you can see, are randomized 1-to-1 to SG with Pembro versus chemo with Pembro, and listed are the chemotherapy agents that were allowed. Nothing really to note up here. I mean, I think this is kind of what we were seeing in Keynote 355 and what we typically use. And the primary endpoint was progression-free survival, and secondary endpoints were overall survival, overall response, and duration of response. In terms of the baseline characteristics, you see that there's 34% represented as with de novo disease, and here highlighting how few patients had prior PD-L1 therapy. And I think so they break it down in terms of enrollment. They said 62% were outside of the North America and Europe, but I believe the further breakdown shows there's a high percentage in Asia, which I think would possibly explain and reflect why there's very few patients on this study who had prior PD-L1 treatment. In terms of the results for progression-free survival, which was the primary endpoint, PFS was superior with SG and Pembro with 11.2 months versus chemo plus Pembro at 7.8 months. And so this was statistically significant and showed a 35% reduction in risk of disease progression or death. And then if you look at the subgroup analysis for PFS, we see that overall that it is SG and Pembro seem to be favored throughout the different subgroups except for the prior PD-L1, and I think that just goes to show that because there were so few that that did receive it prior to enrollment on this study. Overall survival is immature, but it is trending towards improvement in favoring SG and Pembro. And then an important thing to note on this study is that they did allow crossover, and 81% of patients received SG after discontinuing chemo and Pembro. So I think that's one of the highlights of this study is that looking at when overall survival does mature, this will give us information on how sequencing will be helpful. And then tumor responses and duration of response. So objective response rate higher with SG and Pembro, with a median time to response being similar between both groups, and median duration of responses is almost double with SG and Pembro versus chemo plus Pembro. So the adverse events were really interesting. We didn't actually see, I think one of the concerns of this combination regimen is will we be increasing toxicity? And the data from this study shows that they're quite similar, actually, in terms of rates of neutropenia with SG, as well as there was an interesting slide that they reported in terms of immune-related adverse events too. So this was looking at specific interests with SG being the neutropenia, hypersensitivity, and diarrhea. And then also the Pembro adverse events as well, specifically thinking of the immune-related adverse events. And we can see that really these were not significantly higher in the SG and Pembro arm. Key takeaways here is that this is the first phase 3 trial of an ADC in combination with a checkpoint inhibitor for PD-L1 positive metastatic triple negative breast cancer in the first line. And it did show that SG and Pembro had a meaningful improvement in progression-free survival with a delta of 3.4 months. The overall survival data right now is immature, but I think that will really have a huge impact on how we interpret the results from this study. As you know, I think the main question that we're left with after hearing about this is will it be beneficial to give SG first line versus what we're currently doing in real world, which is sequencing in the second line, and how that impacts the survival. And no, the other important thing and I think reassuring thing was that there was no additive toxicity that we saw when we combined these two agents. Other things that we should consider though is that because very few patients did receive pembrolizumab as prior treatment, what do we do about those patients who had recent pembrolizumab exposure, and how would that, like, are they truly benefiting from continuing the pembrolizumab with SG, or would they actually benefit from just SG alone in that setting? And so that really in terms of how to interpret these results, differing between recurrent disease versus de novo, and then also how we now think about sequencing other ADCs after this regimen. Those, I think, are the other important questions that are still lingering. And with that, I think those are the rest of my slides.
Thanks so much, Vidya. Any questions? I think I feel the same. I mean, the major problem that I think we all deal with now are those patients who unfortunately experience relapse while on or very shortly after the 5-drug KEYNOTE-522 regimen. And that's a area of unmet need because it feels like oftentimes nothing touches those tumors. This is interesting for de novo, perhaps, but I don't know how relevant it is to a lot of our practice where patients relapse after prior pembro and platinum and keynote, but open to thoughts. Right. Well, let me see if I can share here. I'm going to finish up with, see if I can get it to work. With just one other study that I thought was, and I hope that this will, are you able to see the slide? Great, thanks. So I was going to finish up with the presentation by Nadine Tung on a neoadjuvant study for HER2-positive disease. This is the COMPASS HER2 PCR trial. And this is a really monumental effort that I think has the potential to be practice-changing if we see additional data. But Nadine kindly shared her slides with me here. So this is the Predicting Pathologic Complete Response. And they actually were able to look at secondary and exploratory objectives in this study of neoadjuvant therapy with taxane, trastuzumab, pertuzumab, or THP, as a single-arm study in patients on the EA 1181 study. So, hold on. Again, this were from Nadine's presentation. They found overall that in patients with stage 2 and 3 HER2-positive breast cancer, the PCR rate with taxane, Herceptin, Perjeta was 44% overall, higher in the ER-negative group, 64 versus 33 in the ER-positive group, which met the predictions based on smaller studies. They found a number of factors that were significantly associated with a higher PCR rate, including a lower level expression of estrogen receptor, including ER0 or negative, higher expression of HER2 by IHC at 3+ versus others, and interestingly, weekly paclitaxel versus Q3 week docetaxel, as well as a higher HRDX PCR score. Interestingly, whether your baseline clinical TNN stage did not predict PCR outcome with this regimen. So as we know, standard of care for patients with stage 2 and 3 HER2-positive breast cancer generally includes taxane-based regimen with trastuzumab and pertuzumab. The main regimens that are used most often in the US include docetaxel, carboplatin, Herceptin, Perjeta. And this study was an optimization or a de-escalation trial to identify whether we could potentially achieve the similar rates of PCR and long-term outcomes with a less toxic regimen. So the primary objectives were the 3-year recurrence-free survival for patients receiving single taxane, Herceptin, Perjeta, if that could be equivalent to the PCR after multi-agent therapy, targeting a recurrence-free survival, of 95%. The data for RFS is still immature and was not presented at ASCO, but what Nadine did present were the secondary aims, which included the PCR rate with THP, as well as a number of predictors of PCR outcome. So this is the schema for the EA 1181 study. Again, a cooperative group trial that was a large study enrolling over 2,000 patients. This opened right at the beginning of the pandemic and actually accrued extraordinarily well to the point where they were able to add additional patients to improve the sample size and power. But again, these were patients that were stage 2 or 3A HER2 positive breast cancer, regardless of hormone receptor status. They needed those patients who had inflammatory disease, T4 or N3 were not included. And stage 1 patients were also not included. So this was really our stage 2 and 3 folks. Patients were registered and then they received paclitaxel or docetaxel combined with Herceptin and Perjeta. The choice of the taxane was at the discretion of the treating investigator. And so you can see the doses here. Patients went on to surgery, and if they had a PCR with no additional invasive disease, they went on to complete 1 year of antibody therapy with trastuzumab, pertuzumab, and endocrine therapy if indicated. If there was no PCR, patients could get treatment according to their physician's choice, but they also were candidates to enroll in the COMPASS residual disease trial, which has yet to report. Again, the primary objective, which was not reported at ASCO, was the 3-year RFS of greater than 92% in Arm A. So this is the consort diagram. Again, a total of over 2,000 patients that were registered. They were just patients in the ER positive cohort comprised about 2/3 as opposed to 1/3 in the ER negative cohort. All the patients who received at least 1 dose of therapy were in the evaluable cohort here in the middle. And you can see that of these, the vast majority made it to surgery and were evaluable for the PCR outcome. You can see reasons for discontinuation are listed here as well. So with regard to patient characteristics, median age was 55. Most were white, but there was actually a really impressive demonstration of representation by Black and Hispanic participants, which is a great thing to see, and it adequately represents the U.S. More accurately represents the U.S. population. You can see most patients again had an ECOG of 0, as would be expected. The division between stage 2A. Again, 58%, and about half of patients had node-positive disease at presentation. The most common taxane received was paclitaxel in 63%. And although not shown here, the characteristics for patients that had hormone receptor positive or hormone receptor negative disease were quite similar. Again, with regard to tumor characteristics, most were ductal as expected. A good proportion, more than half, were grade 3, again, to be expected, and about 36% of participants had hormone receptor negative disease. Some of them had, and then HER2 3+ by IHC was about 80%. When you look at the differences between the ER positive and ER negative cohorts, you can see a lower frequency of grade 3 disease and a higher frequency of IHC 2+ for the ER positive patients, which again falls in line with what I think we typically see clinically. So with regard to the secondary objective of pathologic complete response for breast and nodes, among all patients, it was 44%. Among those patients who had hormone receptor negative disease, it was 64%, and then 33% in those that were the triple positive or hormone receptor positive patients. What I think is actually, and this rate of PCR is pretty similar to what the expectations were, and I think is well with what we see in practice. The notable thing here I would point out that Nadine did point out is less than 1% of patients had evidence of progressive disease during taxane, Herceptin, Perjeta. And I don't know about you all, but that's a question that I commonly get when we start patients on this regimen. And it's reassuring to see a large study that holds up there to suggest that, as we all know, these patients are all very likely to respond to therapy. They looked at a number of analyses to look at clinical and pathologic features which were associated with PCR, and this is the univariate analysis. And things that were associated with a lower rate of PCR included age above 70 and a performance status of ECOG greater than 0. And those that were positively associated included higher grade tumors, lower ER expression or ER negative, and higher expression or more qualitatively higher expression of HER2 by IHC, and interestingly, the use of paclitaxel. And you can see these all broken out here in the univariate analysis. I think the taxane is interesting, and it didn't appear that this was necessarily related to dose, but we can ponder on that difference as well. Interestingly, things around stage, whether you were stage 2 or 3, was not predictive of outcome. So when the analysis was completed by multivariate analysis, paclitaxel continued to be held up in the multivariate analysis, as did ER level of expression and HER2 3+. So these appear to be strong predictors. Another interesting part of this trial was the collaboration and use of a genomic score, specifically HER2-DX. I've ordered this once, but it has not been generally as available in the United States, but it is a genomic test that looks at specific features of the tumor based on the baseline biopsy. And includes 27 genes, including the C listed here: immune activation, luminal differentiation, proliferation, and the HER2 amplicon, to generate a couple of different scores. And the score that they looked at in this analysis is the HER2-DX PCR likelihood score. There is a second score that looks at overall outcomes and relapse, but here it was the PCR likelihood score. And so the question for this pre-specified secondary analysis is whether or not the rate of PCR was significantly higher in those patients who had a high versus low HER2-DX PCR score. And so these were their statistical assumptions and predictions. So what they found is that when they looked at the cohort of individuals who were candidates to undergo the HER2-DX testing for which they had results, they found that the patient and tumor characteristics were balanced among the HER2 analytic cohort, which included 569 patients for this analysis, as compared to the entire study treatment cohort. Again, here, age, race, performance status, grade was also well matched. Sorry, I'm having some, there we go. So what was presented was that a higher HER2-DX score was associated with a higher rate of pathologic complete response, versus a lower HER2-DX score predicted a lower rate of PCR. And this held up whether patients had hormone receptor positive or hormone receptor negative disease. And interestingly, you can see that the proportion of patients with a high HER2-DX score was higher in the ER negative patients than the hormone receptor positive patients as well. But this was a statistically significant difference in terms of the HER2-DX predicting a higher likelihood of PCR. Additionally, this HER2-DX score has high, medium, and low, but what you can see here is that there wasn't really a discrimination between high and medium, so these were collapsed together. So, and most patients had, in the ER negative, had either a high or a medium score, but there wasn't additional discrimination in these two categories. You can see that the majority of patients with ER positive disease had low HER2-DX scores. And again, those PCR rates were similar. When they plug these into multivariate analysis to look at how HER2-DX held up with the other characteristics that were associated with predicting response, the HER2-DX score of either medium or high held up as being a strong predictor and for response as assessed by PCR. That held up with the hormone receptor expression, the ER expression, the HER2 amplification, or the HER2 3+, and the type of therapy received. So there was also interest in looking in exploratory aims that looked at levels of HER2 expression that is provided in a report separate from the HER2-DX PCR score. And so they look specifically at that HER2 score as detected by looking at, I think, mRNA expression in the HER2 amplicon. Also using revealed genomics, they looked by intrinsic subtype, and also at looking at an immune signature, an IgG signature of 14 genes that is also part of the HER2-DX score. And these, again, were exploratory objectives, but that they were actually able to report out in this initial report. And so this is, I believe, I can't see my own slide. I think this was on multivariate analysis as well, but you can see that HER2 expression as measured by the amplicon, intrinsic subtype HER2 enriched, and level of expression of estrogen receptor all were statistically strong predictors of PCR in the multivariate analysis. Again, a lot of data from this particular assay. And so in conclusion, again, Nadine reported that the PCR rate with THP is 44% overall, 64% in the ER negative, and 33% in the hormone receptor positive. If this holds up as RFS, I think this could be a really optimal way for us to consider doing less docetaxel carbo, Herceptin Perjeta, for our patients with stage 2 and 3 disease. There were a number of features that could help predict a higher PCR rate, including lower level expression of the estrogen receptor, stronger expression of HER2 by either IHC or by the amplicon by expression levels. Interestingly, again, clinical TNN stage was not associated with PCR, and the HER2-DX PCR score offered a composite complementary assessment of the likelihood of PCR. Again, we look forward to seeing the 3-year RFS among the patients with PCR and obviously that data is maturing. I'll add here that I want to just give a shout out. I don't have a slide, but I think there's going to be a number of biomarkers that are going to be helping us in the future with regard to our normal gestaltometer. We know how these patients do with therapy, but in addition to potentially HER2-DX coming online, I think it'll be very interesting to see the results of the DIRECT study, which thank you, everyone. The study finished overall accrual quite well, also through ECOG-ACRIN, looking to see if a FDG PET biomarker can predict, is a negative predictive marker for PCR as well. And so one can imagine that in the not too distant future, we may have a test like HER2-DX as well as potentially an imaging biomarker that could allow us to, again, optimize our therapy for this really important patient population. And these were the acknowledgements presented by Dr. Tung. And again, a really great job for a very large study through ECOG-ACRIN that accrued during the pandemic. So I will stop there and happy to take any questions. And thanks, Kaylani, for putting our survey into the chat. I hope everyone's having a great summer. Thank you for joining us. And I think that Lena may have let you know about our upcoming seminars, but thanks everyone for joining. Have a great day.